Good afternoon, everyone. Welcome to our today's CME session on updates on stroke management with Dr. Wondwossen. Uh, I'm Dr. Israfil Musa from the Yetena Weg CME team. I will be your host today, and he also have Simon Mulugeta, who will be my co-host. We will wait a bit. I will start introducing Yetena Weg till most of our participants join. Hopefully, this will be a good session. So I will take a few minutes to tell you about Yetenaweg. Yetenaweg is a digital platform for health workers and volunteers. Currently, it's registered in Pennsylvania, USA as a non-profit and entirely run by our volunteers. Currently, we have more than 70 active members across 5 different countries, and we hope to reach out for more. Currently, you can classify most of what we do into four aspects of our activities. The first one is health promotion. Second one is community engagement. The other is mentorship and skill sharing. When also we have medical education, who is currently running this CME program. Uh, Health promotion. On health promotion, we have few activities that I will discuss further on the next slides. But as an intro, mostly you might have heard of our article writing competition. We currently have lots of articles published in 3 languages on our website, and we're trying to reach more. On these articles, we address the general population, and we try to address basic medical topics that need to be discussed further with the community. It's free for everyone and ad free as well. Anybody can go and review it without any problem. The other we have is discussions on health, like our clubhouse sessions that target. We have one expert at least reaching lots of people, and it will be answering basic health concerns. We choose a topic every time, and we try to address those. We also have health policy and implementation discussions on community engagement. We've been doing blood drive inclusivity trainings with techie papers, on also on mentorship and skill sharing. We have our projects that I will discuss later on. These are a few of the pictures from our community engagement pictures. As you can see, sorry, we have blood donation drives, our inclusivity training with the key paper bag, and also our donation to children with Down syndrome. We provide noise cancelling headphones. The last round was done a few times ago. You can reach out if you want to help. We also, the other is from our ENA and Sine program that we had this year. We had lots of participants, and we had people getting screened for medical problems simultaneously while being entertained by the various artists we have. These are additional pictures from there. The other program is our health article writing competition. The third round was done a few months ago, and Roha Medical Campus is our main partner in this program. Through their foundation, we give to the health article winners travel grant for 2 of them, and also we award oximeter for top 20 winners and Lithuanian stethoscope for top 3 winners. And the top 5 winners will also get internship opportunities at Roha Health and other institutions like MOH. Our next round will start very soon. These are the article winners with their grant from the last 2 years. In the other collaboration we have with Roha is our research fellowship program that we run in Tukurambasa and in St. Paul separately. The first one was done in Black Lion. We started on March 14th, and we had oncology, radiology, and internal medicine department participating. The research grant was for top 4 winners and mentorship for top 10 winners. And in St. Paul, we conducted a separate that was targeting medical students and interns only. And again, a grant was given for top 4 winners. These are the research and QI fellowship winners from Black Line on the residency program. We had Dr. Abel Tenau from internal medicine, Dr. Nathanael from radiology, Dr. Tegest from internal, and Dr. Howie from oncology. And also, these were the graduating winners from St. Paul Medical School. All of them at the time were interns, now on postgraduate. The other program we have is our CME. In our CME, most of you are familiar with it. We try to address many medical conditions and medical topics, and we try to give updates in each one of them with world-renowned speakers from all over the world. Currently, we have participants from globally and as well renowned speakers from our country. And our CMEs are freely accessible for anyone. Currently, we're working in association with Ethiopian Medical Association, Ethiopian Society of Cardiac Professionals, and Ethiopian Society of Internal Medicine. Our aim is to provide trainings for healthcare professionals continuously. Throughout the year of 2024, we have held more than 13 CME sessions. And average attendance, we have between 150 to 100 healthcare professionals, and we plan to have 30 webinars focusing on emergency surgical medical cases, ANT, pediatrics, OBGYN, and oncology cases this year. You can find all of our CMEs, previously done CMEs, on our YouTube channel. All of them, including today's, will be recorded, and the videos will be uploaded in a few time. You can find our channel. We will send it in the chat for our link tree as well. You can also join our Yetena Weg Telegram channel, especially for healthcare professionals, and our also you can follow us on Twitter, Facebook, LinkedIn, and Instagram to get more updates on our sessions. Uh, Lastly, to get CU certificates from this session, there are some set of criteria that we need to achieve. The first one is most of all of you will need to attend the whole session virtually. Minutes attended will be checked at the end of the session, and you have to fill in the Google form we will share later. Both the attendance form and the CME quiz will be on the similar form, and you're also required to get 50% and above on the post-webinar quiz. You will get your results immediately, but the certification process will take 1 to 2 weeks. So if you encounter any problem in that regard, you can reach us through our contact at Enaug, or you can also join our Telegram channel and raise your issues there. Uh, uh, Thank you for listening. Next, I will introduce our speaker today and leave the stage for Dr. Wondwossen. Dr. Wondwossen is a triple board certified physician and associate professor of neurology and neurointerventional surgery at the University of Texas, Rio Grande Valley. He's a board certified in neurology and vascular neurology by the American Academy of Neurology, and CAST certified in neuroendovascular surgery by the American Society of Neurological Surgeons. Dr. Wondwossen completed medical school at the Addis Ababa University of School of Medicine, and later moved on to the United States and completed his internal medicine internship at Howard University Hospital and neurology residency at the George Washington University in Washington, D.C. Subsequently, he completed two Accreditation Council for Graduate Medical Education accredited fellowship programs at the University of Minnesota in vascular neurology and neurocritical care in endovascular surgery and neuro-radiology. Dr. Wondwossen also completed clinical research training at Harvard Medical School. He authored and co-authored multiple peer-reviewed publications and book chapters in stroke and cerebrovascular diseases and neurocritical care. He served as a reviewer for multiple neurological medical journals. He's a senior member of the American Academy of Neurology, Society of Vascular Interventional Neurology, American Society of Interventional Pain Physicians, and Society of Neurointerventional Surgery. About 2 years ago, Dr. Wondwossen moved most of his clinical practice from Texas to Addis Ababa here in Ethiopia after establishing Axon Stroke and Spine Center, the first comprehensive stroke center in Ethiopia. Dr. Wondwossen is currently serving as the CEO and medical director of Axon Stroke and Spine Center here in Addis Ababa. He's also founder and president of Ethiopian Stroke Initiative. Without further ado, I will love to leave the stage for Dr. Wondwossen. This is going to be a very exciting session, and I hope most of you will enjoy. If you have any question regarding the webinar or the topics being shared, you can share your questions on the question and answer box and also in the chats. We'll later on discuss them with Doctor. We'll also announce the time when we will release the quiz. It will be at the end of the session. Thank you for your patience, and Dr. Wondwossen, the stage is yours.
Well, thank you so much for everybody, and it's good to be back. I was here about a year ago, I believe, and we had a great session back then. I would like to thank the organizers, the team at the Yetenaweg, and also the team at the IMA for organizing this session. And special thanks to Dr. Fissum, who invited me over to speak. So last year, I believe it was over a year ago, we discussed about updates or evolution of the stroke treatment, especially focusing on endovascular treatments, particularly mechanical thrombectomy. Today, I wish to talk to you about a few things. We want to go over some basic mechanisms of stroke, and we will go over updates on stroke management. For example, intravenous thrombolysis. We'll talk about standard of care, and then we'll talk about updates regarding that. Then we'll talk about mechanical thrombectomy, and then we'll talk about updates on mechanical thrombectomy. And then we'll talk about Ethiopian experience. As Ezra said, we have moved here back about 2 years ago, and then we have about a year and a half worth of data that we would like to share with you. And then if time permits, we can go over some case discussions as well. So Western data, you have seen this before, I'm sure, but I present it on purpose. That way we have our comparison now in our Ethiopian practice. Stroke is the #1 leading cause of disability in the US, 5th leading cause of death. And if you look in the upper panel, in the yellow here, 33 to 40% of strokes are from large vessel occlusions. That's a very, very significant number. And every 4 seconds, somebody suffers a stroke in the West, and somebody dies from stroke every 4 minutes. Again, time is of the essence. When it comes to stroke treatment, time is extremely, extremely important. Basic breakdown of all strokes, 87% ischemic, 13% hemorrhagic. This is, again, Western data. As most of you know, that in Africa and also Asia, this number is significantly different. Hemorrhagic stroke numbers are much higher than what is listed here. So for ischemic stroke, which is our main focus for the day, there are 2 major mechanisms. As most of you know, thromboembolism is by far the most common mechanism, but hemodynamic failure is the second one. Ultimately, there's going to be a decrease in blood flow to part of the brain. That's what causes ischemic stroke. So thromboembolism is just a blockage of an artery from an embolus, but hemodynamic failure is if someone suffers hypotension for multiple reasons, and if they happen to have a cervical or cranial stenosis, then they will end up having low blood flow scenario in the head, leading to a stroke. And some of the most common causes of thromboembolic phenomena are cardioembolism and artery-to-artery embolism, which is large artery stenosis. These 2 alone account for approximately 50% of basically strokes. And these are the most serious ones, catastrophic ones, and these are the ones that we want to fight. We want to fight all strokes, including small vessel disease strokes or minor strokes, because even minor strokes can be disabling for someone who plays a piano or a guitar. Even if he loses function of a finger or 2, that could mean that he could lose his livelihood. And that's devastating for that person. But generally, killer strokes or strokes that end up causing significant morbidity and mortality are large vessel occlusion strokes. So we'll try to focus on those today. Just to show you a few reasons why someone can have cardioembolic stroke, there are 6 different examples here. On the top left panel, there is what seems to be a mitral stenosis with arterial mural thrombus and also a thrombus on the valve or the mitral valve. Next to it, on the right side, is what looks like infective endocarditis with vegetations and septic emboli, which could cause stroke as well. In the middle is mechanical valves. If anticoagulation is not optimized, someone can lodge a clot in there, and then that could get embolized. And further down to the left is a myocardial infarction, which you see a mural thrombus attached to the infarcted muscle here. And then to the right is a ventricular aneurysm with a clot inside that aneurysmal segment, which could get also embolized to the brain and cause a stroke. And the last one here is to depict atrial fibrillation in someone who seems to have also heart failure. And when you look at large vessel disease, generally, here is an example of the carotid artery. Panel A shows atherosclerotic plaque, stable plaque. It seems to be smooth. There's an endothelial lining on that plaque. But on panel B, you notice that there is an endothelial erosion, or there is some alteration of that gap in the endothelium, which leads to panel C, formation of some plaques on it, platelet aggregates, platelet fibrin aggregates, which could just sit there, or a few of them could break away and go to the brain and cause small strokes. Even worse, you might lodge fresh thrombus on that ulcerated surface where the subendothelium is exposed, you might lodge a thrombus, which could break away and go to the brain, as you can see in panel E, or it may just grow and propagate to become a large occlusive thrombus, completely shutting down the carotid artery. So generally, when we talk about large vessel occlusion, when you have a blockage, as you can see here in the picture, generally the brain sort of compartmentalizes itself into three zones. The first zone is the ischemic core, which we believe, not necessarily 100% true, but we believe is going to be the core, which will be the irreversible infarct that we cannot do anything about. And then there is a penumbra, a tissue at risk, which is a much larger tissue that if we don't do anything, you have to stop it before it burns down. There is an ischemic core that you may not do much about anything. It's called a penumbra. A tissue at risk is what's called an oligemic brain, where there is a generally low blood flow phenomenon. So the penumbra can definitely get recruited into the core, or even the whole brain oligemic region can potentially be also involved in the infarct process. So the idea with mechanical thrombectomy or thrombolysis is to try to reverse this ongoing process, a dynamic process of ischemia. It's not a one-time or a monophasic event. A stroke or ischemic stroke is an ongoing dynamic process in most cases. So this is what you see. When you see someone in your clinic or in your ER, this is what you see. They come in with stroke symptoms. Hopefully, this is what you see, rather. There is no ischemia in this brain. It looks good. There's no bleeding, or there's no obvious sign of ischemia. Of course, you see some small vessel disease in this periventricular region, but when they come acutely, this is old, but when they come acutely, you don't see any obvious sign of ischemia. This is when you want to intervene. This is when you want to give. This is when you want to do mechanical thrombectomy. This is the time to act. Please, I want to warn, or really, I would rather notify young professionals, young practitioners, especially when you see these patients in your emergency room, this is a time to act. And this is what's called an aspect score, and some of you may know this. Aspect score is used to quantify early ischemia on a head CT scan. So if there are zones in these are somehow how they are divided: MCA, M1, M2, M3, M4, M5, M6, as you go up on the cortex, and in the basal ganglia, internal capsule gets 1, lentiform nucleus gets 1, and then the caudate head distribution. And a normal person will get 10 out of 10 because one score. However, if dark, so we decrease a point, and they become dark, each one of them could get darker and darker as the ischemia progresses, and the aspect score will tend to go down to all the way down to 0 in a completed left MCA stroke, for example. So in this patient's case, for example, in the earlier case, this patient has an aspect score of 10. Good time to act. No significant ischemia as far as we can tell based on the CT. That's perfect. However, in this gentleman's case, or this patient's case rather, you notice that there's a large left MCA stroke on the left side. Technically, most of the left MCA distribution is involved. In fact, a bit of the ACA distribution is also involved. Probably this gentleman's, or this patient's rather, CT aspect score is 0. Now, we don't do anything, of course, something like this will happen. This is a brain cutting sample from someone who came in with acute stroke and also died of a cardiac arrest. And this case belongs to one of my mentors at George Washington University. You notice that this whole left brain is midline shift, and there is loss of gray-white differentiation here. The insular ribbon is swollen. And in fact, you might see some thrombus in the Sylvian fissure here, probably distal M1, M2, or MCA bifurcation. This is what you don't want to see. And of course, you don't want to see this. This is chronic changes with encephalomalacia. You notice that this whole brain is just eaten away from this, just becomes filled with fluid in patients with large vessel occlusion, strokes especially. So now, coming back to the treatment. As you know, we have 2 types of treatments: medical management and surgical management. Now, mechanical thrombectomy is a surgical management of stroke. So TPA can be given up to 4.5 hours. It is a standard of care for the last nearly 30 years. Mechanical thrombectomy has become standard of care since 2015, so to speak, maybe 8-9 years. Before that, of course, we've been doing mechanical thrombectomy before that, but evidence came in aggressively after 2015, and that's when, since when, we're now using mechanical thrombectomy as a standard of care. Can be given up to 24 hours. Definitely a lot of indications for patients who may not be candidates for TPA, who are on anticoagulation, recent strokes, all the contraindications for TPA, in which cases mechanical thrombectomy can be offered. And all of you know, I'm assuming that TPA was approved in 1995 as a second-generation thrombolytic agent. As you know, the first-generation thrombolytics are urokinase, streptokinase, all these drugs are first-generation. And then with better safety profile, TPA, which is a second-generation thrombolytic agent, has been approved since 1995. And up to approximately 2008, we were only giving it within the first 3 hours. And then after 2008, when ECAS-3 trial came out, then we extended the time window from 3 hours to 4.5 hours. So IV TPA can be given up to 4.5 hours. How efficacious or what's the efficacy of IV TPA? If you look at this chart of 100 people, if you give it to all 100 of them, 32 of them will do very well. In fact, 13 of them, the ones that you see in deep back to normal or near normal condition, but all of them in green will improve from what they came in with. If you see everybody else in white, they don't change. They improve for, their stroke symptoms remains the same. They don't get a side effect from TPA, or they don't improve. If you look at the bottom, 6 people here you see will have a side effect. That's where the 6% complication rate comes from TPA. Now, 3 of them with a black mark on their chest or on their abdomen, I don't know where it is. Those 3 people, they will have initial worsening, but somehow they stabilize afterwards and somehow fall back to their baseline that they came in with. But the ones in red, the 2 on each side of this gentleman in dark red, they will have major worsening of their ischemic symptoms from hemorrhage, and 1 person will either die or end up having a major stroke or severe disability. So that's what TPA does. It's a standard of care. We have been giving it forever. I have given it for 8, and it's a good drug. Rare, despite what this chart to counsel family. So luckily, I also ended up giving TPA for the first time for a stroke patient in Ethiopia on December 19, 2022. And that was a big honor to do that with my team. Now, since today's talk more about updates on stroke management, what is out there? I mean, what's, as far as updates, what's there for stroke? As far as IV thrombolysis. Now, our center, as a stroke center, we have moved to using tenecteplase for TPA patients. Tenecteplase is a 3rd-generation thrombolytic agent. Activase or TPA, the one that was now a lot of the practices in the developed world have moved to tenecteplase, a 3rd-generation thrombolytic, because it's a good drug, a much better drug in terms of efficacy. It has much more specificity. Its fibrin specificity is much higher than TPA, approximately 15 times more fibrin specific, and 80 times less affinity to what's called a tissue plasminogen activator inhibitor. There is an enzyme, an endogenous process that tends to deactivate thrombolytic agents. Tenecteplase has 80 times, which means it is more effective, it's more efficacious. And it has a longer half-life than TPA, the regular TPA activase. Half-life for activase is like 4 minutes. Tenecteplase's half-life is approximately 22 minutes. So it's more powerful. It has longer half-life. It's more clot-sensitive, or clot-specific rather. So over the last nearly a decade, we have had multiple clinical trials looking at tenecteplase, comparing tenecteplase with itself at different doses from 0.4 milligrams per kilogram to 0.25 milligrams per kilogram and so on, and then trying to find out the best dose for treatment of patients from the 2nd-generation thrombolytics, and really outlines all the clinical trials tenecteplase for stroke. As you know, it has been used for coronary thrombosis by cardiologists for a very long time, and now we're bringing it into the stroke world. In general, as I spoke earlier, 0.25 milligrams per kilogram is the best dose that we know. And overall, it is convenient to administer. And in many ways, it's being adopted in many centers across the globe. And we, as Axon Stroke Center, have also adopted using tenecteplase. Now, just last week, June 14, as you can see at the bottom, the New England Journal of Medicine, more stuff came out regarding tenecteplase for acute ischemic stroke, that it can be used beyond the 4.5 hours window, in fact, up to 24 hours in some remote centers with no access to mechanical thrombectomy. We're talking about large vessel stroke. However, if they don't have if they don't have any access for mechanical thrombectomy, they used it in a Chinese study. So tenecteplase showed slightly more benefit compared to the standard of care. There's some criticism already building up on this Chinese study as, if these are large vessel stroke patients, how come is their median NIH stroke scale is only 10? As most LVO studies, median NIH stroke scale is around 17 or more. So one of those criticisms are building up. But however, their claim is that it might work, and more centers or more study is needed to corroborate this finding. But it's hopeful that at least we can do something for those patients who do not have access to mechanical thrombectomy. Same day, June 14, reteplase, another third-generation thrombolytic agent, has been, again, in a Chinese study, shown to have a better efficacy than alteplase. They used a bunch of mild stroke patients, median NIH stroke scale around 6, and then they showed that good outcome, which is modified ranking scale 0 to 1 at 6 months. I think at 3 months rather, at 90 days. Has been 79% for reteplase and 70% for alteplase, and safety profile has been great. So a lot of people think reteplase is a good drug. It has less fibrin specificity compared to tenecteplase, for example, even compared to alteplase. But they believe that this good balance between risk versus benefit somehow helps reteplase to be a better drug than alteplase. We'll see. Once again, it's a Chinese-only study. Usually, as you guys know, as most of you know, multiple studies across the globe need to come out corroborating such findings. That way, they become practice-changing. They have to be corroborated by studies in other parts of the world, not just for the study to be representative of other human beings from all kinds of walks of life, but also, to just confirm that this is something that can be, trusted. So that's about IV thrombolysis. So we talked about standard of care, about IV TPA, and the update on IV TPA. We talked about tenecteplase and its comparison against alteplase. We talked about reteplase. So all these IV thrombolytics are coming for use to us, and it's all good news. Next is mechanical thrombectomy. What's new in the mechanical thrombectomy world? I don't know if I showed this slide before. This is what we discussed, I think, last year when we talked about evolution of mechanical thrombectomy technology. And as I might have said before, I was very lucky to be there in training in the US between 2006 and 2013, exactly as these devices, developed and being used on patients. I tried all of them because the first device, called Mercy device, was produced in 2004, but it came to use in 2005 and 2006 when I started residency. I then saw Penumbra device came out. These are devices that grab the clot from the brain and removes it. And then by 2012, we have stent retrievers, the famous ones. And then by 2012, we have what's called a Solumbra technique, devices with suction catheters. And then since 2013, we have a slew of thromboaspiration catheters, almost 10 of them by now approved by the FDA. For use as a direct aspiration of thrombus from the brain. So it has evolved so much. This is what a Mercy device looks like. Was not very good, to be very honest with you. I have been thrombectomy cases for almost 6 hours trying to remove the blood clot from the brain. Did not work as much, and it fell out of favor very quickly. Then came the penumbra suction system with a separator wire. It also fell out of favor because separator wire was causing some perforations and so on. Later on, the stent retrievers look like this. This is what a stent retriever looks like. This is what grabs the clot. The clot basically, invaginates, or so to speak, sort of infiltrates into these wires, and then it attaches to the wire and then gets pulled back. And different kinds of devices came to the market: Solitaire, Trevo, and others. I want you to know about these devices when you see their names on our reports, so you know about them. And then this is basically what a thrombectomy looks like. Some of you, I'm sure, saw this, but the Solitaire stent retrievers work in this fashion.
Position the balloon guide catheter as close to the fitting of the guide catheter, and then connect the continuous plunge. With the aid of a suitable guide wire, hold the guide wire in place and advance the microcatheter. Position the microcatheter distal to the thrombus so that the usable length portion of the Solitaire FR will extend past each side of the thrombus when fully deployed. Once the microcatheter is in place, remove the guide wire and tighten the RHV to secure the catheter. With the aid of fluoroscopic imaging, carefully advance the Solitaire FR until its distal markers line up at the end of the microcatheter. To deploy the Solitaire FR, loosen the RHV. Then carefully withdraw the microcatheter while holding the Solitaire FR in place until the microcatheter tip covers only the proximal marker of the device. The usable length of the deployed Solitaire FR should extend past each side of the thrombus. Tighten the RHV around the microcatheter. Angiographically assess the revascularization status of the treated vessel. Inflate the balloon of the guide catheter to occlude the vessel. To retrieve thrombus, slowly withdraw the microcatheter and Solitaire FR as a unit to the guide catheter tip while applying aspiration to the guide catheter.
So, yeah, that's what it looks like. And then basically a blocked right middle cerebral artery here, just before the trifurcation. It was blocked here. You see the thrombus right there as a sort of a gray zone. And then this is after it has been revascularized, and some sort of a very white clot came out. So, when thrombectomy came out to be the standard of care for patients who are presenting within the first 6 hours, there were a bunch of studies, as I said earlier, from across the globe. MR Clean from, let's say, Portugal, Swift Prime, North America and Europe, Extend IA from Canada, Escape from Australia, Revascat again from Europe. All these trials came out with, showing off, so to speak, mechanical thrombectomy is significantly, changing the lives of large vessel occlusion patients by significant margins when they are compared with standard of care at that time, which was only medical management. So 59% versus 33%, 88% versus 60%, 90, 71, 72, 53. So these were all, great trials, so to speak, and all of them landed in the New England Journal of Medicine. And these led to the mechanical thrombectomy, who had mechanical thrombectomy. And the number one reason for that was development of these efficacious, devices such as stent retrievers. A number needed to treat for stroke patients with mechanical whatever you call it. So this was network as a maybe. But again, I guess let me know. I can stop anytime you want, and let's keep moving.
I'm sorry. Can we track back a little bit? I think most of the
sure.
attendees did not hear the slide.
Okay, this one here. So this slide basically shows most of the randomized clinical trials showing that mechanical thrombectomy was significantly better for patients with large vessel occlusion strokes compared to the standard of care at that time, which was just medical management or just TPA only or without TPA. And all of these, randomized clinical trials were published in the New England Journal of Medicine, and they basically led to changing practice as we know it for stroke patients. And the number needed to treat was anywhere between 3 to 4 to 5. And when you compare that number needed to treat, for example, for performing PCI in coronary thrombosis versus, thrombosis for thrombolysis only for STEMI, the number at the NNT is almost 17. So the evidence for mechanical thrombectomy in the stroke world is significantly stronger. In fact, it's one of the most powerful evidences that we have in neuroscience, if not also in other science areas. So that was great. Up to 6 hours, thrombectomy was approved, and we're happy. But then guess what? By 2017, we have 2 large clinical trials expanding the window to up to 24 hours. Dawn and Diffuse 3 trials. I was very lucky to be part of the investigators team in the Dawn clinical trial, which also published in the New England Journal of Medicine, which showed that patients who came in all the way up to 24 hours, as long as they have some penumbra, as long as their aspect score was good, the functional independence at 90 days was significantly better, 52% versus 13% in the control group, with an NNT of 2.8 only. This finding, along with the finding on Diffuse 3 trial, which is the second trial here, led to the new guideline by 2018, which then expanded the window up to 24 hours. Now, time versus physiology. Some patients may be 17 hours out from their stroke, but they could still benefit significantly from thrombectomy because they have their physiology. Their physiology is better. They have been able to develop collaterals, or they have collaterals, and they did not end up stroking, out all the way. So when they get reperfused, revascularized, they end up getting significant benefit. So witness strokes, wake-up strokes, we used to just ignore all these patients. If they're wake-up strokes, okay, we don't know the time of onset, we cannot do anything for you. That's what we used to tell them. But no, nowadays, as long as their aspect score is greater than 6, or greater than or equal to 6, and an infarct core size of less than 70 ml, now we have a new standard of care. So that's what it is. Now, again, today's topic is about updates. So what updates do I have for you? Now, once people knew this, that mechanical thrombectomy has significant benefit for patients with large vessel occlusion, they're saying, you know what, why don't we go further down on the aspect score? As I showed you earlier, aspect score, the higher the score is, the better off you are. So if you have a normal person has an aspect score of 10, now mechanical thrombectomy has been approved for aspect score of 6 and above. Now people are asking, how about 3 to 5? It has not been studied. Why don't we study it and see what happens? Because, ultimately, instead of settling down for the CT scan, whatever it shows us, if it says tissue is dead, instead of just keeping quiet, why don't we take these patients? We're not going to do anything for them anyways. They're just going to be managed conservatively. Why don't we randomize patients to mechanical thrombectomy and medical management against medical management alone? So as you can see, 3 trials: Rescue Japan, published in 2022. SELECT2, Rescue Japan is a Japanese study, as the name indicates. SELECT2 is a North America, Europe, and Australia study. Angel Aspect is a Chinese study. And all of them looked at large cores. What if patients have a large stroke already? They still have a large clot. Let's take them out. What happens? Now, if you look at all of them, they showed some, all of these 3 clinical trials showed that there is some benefit with mechanical thrombectomy. Albeit very modest, very small. For example, Rescue Japan had only 7 percentage difference between, mechanical thrombectomy versus medical management group. And the same thing, Angel Aspect, 30% versus 11%. And for SELECT2, 20%. Again, updates on mechanical thrombectomy. What is new out there? Well, like I said, we've always been asking this question. If it's a large stroke, a large blood clot, and we've seen it from multiple clinical trials in the past, TPA doesn't dissolve it. It doesn't touch it. Because, blood clots from the heart, for example, can be as big as 5 millimeters. They can be as long as, let's say, 8 to 15 millimeters in length. And TPA usually doesn't dissolve those types of clots. So then you give TPA and you still end up taking the patient to cath lab to remove the clot mechanically. But now you are taking a slightly higher risk because now the patient is on TPA, fully loaded, and you are in the brain in a 2 millimeter, 1 millimeter artery trying to remove the blood clot. So you're like, okay, TPA did not work, but now it's making my life, but more importantly, patient's life more complicated. So, so then you would wonder, why do I give TPA for someone who has such a large blood clot? So for patients with a large blood clot burden, we thought maybe a study should be done and see, if we can avoid TPA. Unfortunately, all these 3 randomized clinical trials did not show non-inferiority to giving TPA and continuing to mechanical thrombectomy. You can check them out on your own, but it's an interesting concept to push forward in the future. But as of now, even a Chinese study here showed no significant difference, maybe a small benefit, but not a whole lot. So the guidelines remain today that a stroke patient gets IV TPA before they go to mechanical thrombectomy, and that's how things are as of now. And the last maybe update that I can tell you is that what's called a CHOICE trial. Now, CHOICE is an interesting trial because as you might know from cardiology literature or practice, after you open up a blocked artery, patients don't improve. Or the heart muscle will end up going a myocardial infarction. The same thing we see it in a stroke, what's commonly referred to as non-reflow phenomena. Now, this is after you remove the big blood clot, maybe the microcirculation is still occluded by microthrombi. So you're happy that you opened up the big vessel, but then the patient is not getting better. So people are asking, you know what? After opening up the big vessel, why don't we go ahead and infuse, thrombolytic agents? We're there already. We are in the artery. Why don't we just infuse just a little bit of TPA, and so on? So this study looked into that. Patients who had mechanical thrombectomy alone, as compared to patients who had mechanical thrombectomy, opened up the vessel, and then had a little bit of an infusion of TPA intra-arterial. Now, unfortunately, this study was interrupted early because of COVID and some enrollment issues. But they had enrolled, close to 2,000 patients, and they showed benefits of giving intra-arterial TPA after successful mechanical thrombectomy, with a significant benefit for patients. So these are some of the updates that I have for you. So what we have covered so far is we talked about standard of care for large vessel occlusion patients, and we talked about updates in the area of IV TPA, in the area of mechanical thrombectomy, and also a combination of IV and IA TPA along with mechanical thrombectomy. Now, moving on to our Ethiopian experience. As you know, I've been thinking about coming back to Ethiopia for a long time, for nearly a decade. And as we noticed, the third world is being consumed into having the larger share of stroke. As you know, probably approximately 70 to 75% of stroke burden is now in the third world, unfortunately, while we're still dealing with issues with infectious diseases. We now have the bigger burden of cardiovascular diseases. And, I was looking at data like this from 2013 from Dr. Johnston and his group from UCSF that, in this global stroke belt, there is an excess in stroke mortality as compared to cardiovascular or cardiac mortality. So Ethiopia is among some of those nations who has a slightly excess in stroke mortality, even compared to MI. And that was interesting. And more importantly, if you look at some local data published by Misgano and his group in their paper called Patterns of Mortality in Public and Private Hospitals of Addis Ababa, published in 2012, this shows you that in this graph, the top line, which is group 1 disorders, which is communicable diseases, it is decreasing. The prevalence of those diseases is sort of going down over time, pursuant to our being able to be a more developed country, being able to treat infections more effectively, including HIV, being able to feed our population better. But then if you look at the middle line, which is non-communicable diseases, of which approximately 50% are cardiovascular diseases, it's kind of picking up starting from 2009 and so on. So this was interesting to see, which actually also corroborates this notion that the third world is being affected by a stroke for multiple reasons. We can discuss that later on. And more importantly, the EPIH or the EPHI data that was presented in 2021 showed that stroke is a #1 leading cause of premature mortality for these middle adults between the age range of 50 and 69 years old. Imagine this is much, much higher than, ischemic heart disease and other diarrheal diseases from 4 to 7. So with all this in mind, and of course our interest in moving back and helping our people, we moved back to Ethiopia in September 2021 and started this stroke center. So we were inaugurated in October 2021 officially as a stroke center. And we have been working since then, and I'd like to share some of our experience with you. First thing, we have what's called Ethiopia Stroke Initiative Organization. It's a non-for-profit organization established in the USA, in Texas. And the purpose of this non-profit organization, a 501c3 company, is to help stroke education, to promote stroke research. And so one of the things that we do at Axon Stroke and Spine Center is train fellows. And as soon as we started, we enrolled 3 fellows for vascular and stroke neurology subspecialty. These are all neurologists, Dr. Sabler, Dr. Salam, and Dr. Fikru. They got training through an online course directly, given from the United States, from professors in the US. So Ethiopia Stroke Initiative sponsored their training. As you know, they are neurologists. They get a ton of practical experience between our center as a private facility and also where they teach at Tukur Anbassa. And so with a lot of rich, rather practical experience and didactics from the US, from distinguished professors, they did their first year, or their 1 year rather, training and graduated last year. And after those 2, we have 2 more enrolled this year, Dr. Yodit and Dr. Samuel. They are the current fellows in stroke and vascular neurology. Although Dr. Samuel is also a neurosurgeon, he's going to become also a vascular neurologist or a stroke specialist. Now, so Ethiopia now has more stroke specialists coming up, and hopefully we're going to continue to expand and push for training. In fact, to be very honest with you, being able to train is one of my main reasons to come to Ethiopia. And in fact, if I don't train, I don't think I'll be able to stay here, to be very frank. But this has been going very well. And we also have a neurointerventional fellowship. Dr. Sam is like a Superman. He is doing a neurointerventional fellowship. At the same time, he is taking the didactics in the course to become a stroke specialist, because it is a requirement for an interventional fellow to also have completed a vascular neurology fellowship. So he's doing both at the same time. His fellowship is progressing very well. And this is where he is showing off and doing a case by himself, a DSA or a diagnostic angiography. While I am sitting, of course, monitoring and be ready to help. And Dr. Tariku is our famous intensivist and anesthesiologist. He's also tending into our pain management fellowship. And we have, a whole slew of pain management programs. We have brought, as some of you know, the first radio frequency ablation machine to Ethiopia. And this was back in 2021, where I was applying radio frequency ablation for someone with back pain. And we can offer a whole slew of pain management procedures. Now, what does our preliminary stats look like in our stroke center? Since our inauguration in the last 1.5 years, we have seen a total of 3,400 patients, of which almost a third of them are stroke patients. We are a neuroscience institute, so we have we see a lot of patients, all sorts of neurological diseases. We see Alzheimer's, we see headache, we see epilepsy, we see all sorts of diseases, but stroke takes a third of the share of our patients. Distribution by sex, maybe 55% male, 45% female. And as you can see, distribution by gender, for both sex, male or female, the significant the significant burden of stroke is in the age range between 50 and 70, or 50 and 80 rather, for both men and women. Maybe after 80 years of age, there's more women in the mix than men, and this is to be expected. But what's also interesting is that stroke in the young, what we call stroke in patients under the age of 50. I'm sorry for the little typo here. It should be greater than 50, not greater than or equal to. Stroke in the young, by most definitions, is less than or equal to 50 years of age. And above that is, regular adults, or middle adults, or older adults. So if you notice here, almost 31% of our stroke patients are young. And this is scary. This is something very scary, rather. Although there is a mix in the hemorrhagic stroke in some of them, from aneurysms in others, this number is high. And this calls for action, because this is what we see in practice too. There is a significant number of patients with stroke in their 30s and 40s. But overall, our distribution of stroke by subtypes, 37% hemorrhagic stroke, 63% ischemic stroke. Notice what I showed you as in my first slide in the US, it is 13% versus 87%. But in Africa, in Asia, as was suspected, the proportion of hemorrhagic strokes is much higher. In the younger population, less than or equal to 50 years of age, slightly higher hemorrhagic stroke proportion, up to 45%, but like I said earlier, diseases like aneurysms and AVMs rupturing and coming in with bleed in the brain are also included in this group. So kind of making the picture a little bit, the number a little bit higher, but this is the reality for those patients who are young. Now, if you look at TOFS criteria in terms of etiology of stroke for our patients, large vessel occlusion accounts for approximately 25%, small vessel disease, 12%, cardioembolic stroke, 25%, and so on. And undetermined etiology is about 31%. Now, hypercoagulability and others will fall into this other determined etiology category. Surprisingly, since Ethiopia is not on an island, so to speak, this picture or this number is, similar to what we saw in the West. Between large vessel occlusion and cardioembolic strokes, they account for approximately 50% of all strokes. And that's exactly what we see here. And a third of our patients are cryptogenic, or strokes of unknown origin. And that's exactly what we also show on our data at Axon Stroke and Spine Center. Now, for those patients under 50, the cardioembolic strokes are slightly higher. And then, large vessel occlusion atherosclerosis goes down to approximately 15% compared to all patients, where it's now 25% almost. In younger patients, it's 15% large vessel occlusion, 23% cardioembolic strokes. And it's interesting. Yes, it's plausible, because a lot of some patients with rheumatic heart disease and others also come in the mix. So it's no surprise that cardioembolic strokes are more common in this younger patient population. But it's also scary, once again, to see 15% of strokes in younger people are from a large vessel atherosclerosis. Means, a lot of these patients have high blood pressure, diabetes, they have plaques, atherosclerotic plaques in their large arteries and so on. So this is something to worry about. Looking at hemorrhagic stroke, breakdown by etiology, again, by far the most common cause is hypertension. So hypertensive bleeds are approximately 46%. And then, of course, aneurysmal rupture. We are, the aneurysm center of the nation to be as far as endovascular therapy. We see a lot of aneurysm cases, and of course, approximately 24% are aneurysmal subacute hemorrhages. and the others are, as you can see down here. Now, how about modifiable risk factors? In our patient population, we noticed that hypertension is, or in all stroke patients, I mean, among all stroke patients, 65% almost have hypertension. Again, this is very similar to data out there in the West. Like 70% of all stroke patients have hypertension. For example, if you look into some Western publications, that's what we see. 64.6% of all stroke patients had hypertension, and 35.23% had diabetes, and so on. Now, some heartbreaks here. Symptom onset to time of arrival to our emergency room. As you can see, we broke them down, under 3 hours, 3 and 4.5 hours, 4.5 to 6 hours, and so on, just for convenience, based on treatment options that are available. So you notice that the vast majority of our patients arrive late. In fact, a significant number of our patients arrive beyond 24 hours window. And this is sad because we're not doing enough, or we're not treating enough stroke patients. Being the first and comprehensive stroke center in the country, we don't do enough, or we don't treat enough stroke patients. And that needs to change. And all of you in attendance who are medical professionals need to advocate for this. Yes, Ethiopia is a big country with 126 million population. Ethiopia needs, hundreds, if not thousands, of stroke centers across the country. We started it, and we believe that with the people that we're training and more centers opening up, we will expand. But like I said, being the only stroke center at this time and treating very few stroke patients with TPA and mechanical thrombectomy, as I will show you in a little bit, is sad, mainly because patients come late. Whether they come straight to our ER or whether they get referred from other hospitals, majority come very, very late. As you can see, under 24 hours versus more than 24 hours, they're almost equal. So what does our inpatient profile looks like? Median duration from onset of stroke to admission, 24 hours, which is sad. Median length of stay, 6 days, which is really comparable to other published data out there, or our experience in the West. We will publish all this with some comparative analysis in the near future. We have referral from other institutions. In fact, significant number of our patients, approximately 36%, get referred to us from our other centers. We just wish that these patients come in early and they get referred to us early. It is really, really sad how many patients arrive so late. I know, every center or every place wants to have a piece of the pie, so to speak. But even if they need to do CT scans and MRI scans, which MRI is not necessary to manage acute stroke, as you know, but even if they have to do all these tests, do them quickly and then send them out quickly, at least so that we can intervene. But in most cases, patients are significantly delayed, by the time they arrive to our institution. So I hope this will change, because, there are lives. These are, humans. A lot of these patients could die because stroke is still a major killer, and a number of them will end up having major disabilities. So I hope all of you will advocate for stroke treatment in the early hours, and this will change over time. We also refer patients out to other institutions for multiple reasons. It could be for dialysis, for example, since we don't have a dialysis unit at our center. It could be for cardiac diseases. For example, if once we stabilize their ischemic stroke or hemorrhagic stroke, we might send them out for a coronary intervention. So our referral rate is approximately 10% also. Discharge home, approximately 78.6%. They either continue their treatment home or they just do outpatient follow-up. But we end up having a very good number, to be very honest. Close to 80% of patients go home. Our readmission rate is approximately 8 to 10%. We're going to refine this data more. And by the time we publish this paper, we will have much more reliable data for you. But this is a preliminary data that shows you that our readmission rate is approximately 8%. Now, if you look at ischemic stroke in general, it's a bad disease, or hemorrhagic strokes. their readmission rates in the West even is somewhere around 15 to 17%. So from that standpoint, we do very well. And the reason why I say this is because in the West, patients, when they get discharged, they go to rehabilitation facilities where there are doctors. They stay there for 4 to 6 weeks. They are taken care of very well. They don't aspirate just from reckless feeding at home by maybe poorly trained professional, home care service provider, and then they don't come back to you with massive aspirations, as we have seen in some of our patients. So although it's common to see readmissions from strokes in general, in Ethiopia, where we send patients home for home treatment or home to continue their home care, I think we do very well with these numbers. And the rest that you can see, especially with the mortality number, we're very happy with that number as well. We have very, very low mortality rate. Now, going to the interventional side of things, we have done close to 700 interventional cases, as you can see the breakdown across the board. I mean, more importantly, brain aneurysms close to 85, but look at the mechanical thrombectomy numbers, 37 only. Nearly 1/3 of the aneurysm volume. In fact, aneurysms are much more rare compared to ischemic strokes, but we're doing much more brain aneurysms than strokes. This tells you that there is something wrong. There is really a big problem out there, both in terms of patients not coming in early, and also the referral pattern has to improve, to be very honest with you. This is a breakdown once again, and we do compare well. And again, this poor referral for stroke patients, or stroke patients are coming in late for multiple reasons. In fact, it's not just, referral patterns. Patients themselves, for religious reasons, for cultural reasons, they feel like they will get better if they just wait it out, if they don't do anything about it, if they just sleep over it, they just stay home, thinking that they will get better. And by the time they show up, they're out of the window. For TPA, they're out of the window for mechanical thrombectomy. So there is also cultural and religious factors in it, and our society needs to be educated better as to what is a stroke and what could be an evil spirit, and so on and so forth. So, but anyhow, this is a problem in Africa in general. I have this, word of mouth data, because if you ask the industry means people who sell us the devices for thrombectomy and others, they will tell you how many cases Kenya is doing, how many cases South Africa is doing. And we compare very well. I mean, it's the same thing. 15 centers in South Africa, for example, they do probably 180 strokes per year. In Cape Town alone, there are 5 programs. So, 10 strokes thrombectomies per site per year, which is a very low number. So overall, we compare okay, but Ethiopia is also a big nation, right? We're, like 3 times more than Kenya, and maybe twice than South Africa. We should do much, much better than that. But I just wanted to show you some simple, unpublished comparison. How do we take care of emergencies in our hospital? Mechanical thrombectomy 47, as I showed you, but look at the IV TPAs. We have only given IV TPA for 4 patients. Isn't this sad? In a year and a half. Why? Because it's given within 4.5 hours. Patients don't come on time. And they should be able to arrive quickly. And those 4 patients that we gave them to, they did very well, to be honest. 2 of them ended up going to mechanical thrombectomy. Both of them were white Americans. No, actually 1 American, 1 German. They end up having a mechanical thrombectomy, and one of them has been published in our social media page, how he did very well. And the German lady also did very well. She went back to Germany for further rehabilitation. The other 2 did amazingly. One I will show you the video of, and the other one was actually a medical doctor who did very well. So we just feel like we're not treating enough because patients don't show up on time. Now, let me share with you one quick history of a patient, 59-year-old lady who came in within 1 hour of her symptom onset. Her daughter is a medical doctor, a GP, who this lady was on a Sunday. She was going to church, and then she suddenly fell down. So her daughter, who's a medical doctor, noticed that, oh, mom, you're having a stroke. We have to go to Axon Stroke Center. Her last known well time was 11:15. She arrived to our ER at 12 p.m., literally 45 minutes later. Her NIH stroke score was 10. Left-sided weakness, CT scan was clean, aspect score of 10, and CTA showed right MC occlusion. And hey, on a Sunday, we showed up. So door to needle time was 30 minutes. So she showed up at our door at 12 p.m. We gave her TPA at 12:30 p.m. And she made a remarkable recovery. And the next day, her CT showed a small stroke, as expected. Remember that core versus penumbra I showed you? A small core here in the basal ganglia, right there. That's just a small core, but as you can see, her whole right MCA, which was at risk, has been spared just from TPA alone. She did very well. In fact, within 2 hours, she started moving her left side, and 6 hours later, she had no symptoms. And this is her word.
ሰውነቴ ራሱ ሲመለስ ይታወቀኛል። እያንዳንዱ ነገር አካሌ በሙሉ በያለበት ተመልሶ ይዤ ምንም አይነሳም ነበር፣ አይሰራም ነበር። ቀጥታ ሁሉ ነገር ይሰራ። አሁን በጥሩ ሁኔታ ሆኜ መራመድ እችላለሁ። ራሴ ወጣለው ገባለው ካለው የወደፊት ለመናገር እችላለሁ። በፊት እንዳለኝ ማውራታችን ብላሴ
So lots of great stories that I can tell you. This is a basilar artery thrombosis, which was, I don't know if some of you have seen the movie, The Diving Bell and the Butterfly. If you haven't, it's on Netflix. This is a French journalist who had a basilar artery thrombosis, who nearly died, but ended up surviving, in what's called a locked-in state, which is basically you cannot do anything. You are quadriplegic. You cannot even move your eyes sideways. You can't swallow. You can't eat. You can't even move your eyes sideways. You can only move your eyes upwards. That's it. The only function that he can do is moving his eyes up or down. It's called a locked-in syndrome from a basilar artery occlusion. That CT scan is what is there. He's a fascinating story. The book and the movie itself is, we were given this book when we finish residency or fellowship in vascular neurology. And I recommend for some of you who are interested in stroke to watch that movie. Anyway, we had a patient with the same thing. This gentleman flew from Dubai. And then that same evening, he hadn't taken his medications. He was supposed to be on anticoagulation. He hadn't taken it for a few days. Now, after thrombectomy, just literally 2 days later, he was walking on a walker. We have some great success stories. And this is what his basilar artery looked like before and after recanalization. Another lady who had left-sided complete paralysis. She can't move her left side. You see, he can test it by letting it hit their face. But they'll let it hit their face because they are completely paralyzed. When I ask her to move her right leg, her left leg, she's moving her right leg. So this is 2 days later in the ICU, moving everything on the left side. She also came in within like 6 hours of her symptom onset. She did not qualify for IVTPA, but she qualified for mechanical thrombectomy, and she was able to move her left side the next day. Both patients, thrombectomy patients, did not qualify for IVTPA, but they did very well. This is her mechanical thrombectomy pictures. As you see, right MCA blockage, frontal film, complete reperfusion, lateral film down here, complete reperfusion. So we do a lot of stuff. We do a lot of outreach. We teach in public universities, hospitals, UN embassy, UN clinics, embassies. We go around giving talks, try to raise awareness. As I told you, we are in trouble. We are not treating enough patients with a stroke, even when we have the treatment available. There are a lot of issues, cost and stuff, but a vast majority of our patients may not afford treatment, but millions can afford it too. So that being a different discussion, we really are doing a lot of work out there to do a lot of outreach. We are on print media, on TVs, trying to create awareness, and going regionally in Kenya to try to source, devices, medications, and so on, and to create a regional collaboration to try to create some sort of regional market so device companies can see us as a big market and reduce, pricing on their devices. That also transmits to our patients and so on. Been in South Africa, operating, teaching, giving lectures, and operating and proctoring cases in South Africa. So we do, a lot of work out there. I think for our effort in Ethiopia, the Society of Vascular Interventional Neurology in the US gave us this recognition. We're very happy to continue to do what we do. I think I've just spoken for maybe, I don't know, about an hour. If I have like maybe 2 or 3 minutes, I can show you some other non-stroke interventional cases that we do. We do carotid stenosis. This is an angioplasty case. Some of you may not have seen carotid angioplasty and stenting. This is what it looks like. Can you see it now, right? You can see it. You will see a balloon inflating here, a high-grade stenosis in the middle here, and it's going to give up now in a little bit, and it will just give up like that, right there. Now the stenosis is no more. You have placed the stent. The patient is fully revascularized. Anyway, the others are brain aneurysms. They are all on our website. Brain AVMs, more strokes, arteriovenous malformations, high-grade carotid stenosis. As you can see, even a 99% stenosis like this, we can go through it very carefully. And just like that, with a microwire, and once we get distal access, then the case is done. And a beautiful stent placed there, reperfusing the patient. And once again, a lot of brain aneurysm cases on our website. Brain AVM, very ugly vascular malformation here, which ruptured in a brain stem of a young person, which we treated and literally cured that AVM. As you can see, it's no more there, and so on. So again, I will invite you to go and look into our websites. And this is high-grade intracranial stenosis, basilar artery. The gentleman, the movie that I recommended, a stroke like that happens from a very high-grade stenosis like this. This is 99% basilar stenosis that we treated with balloon angioplasty and stenting. But once again, thank you for your attention. And if you have any questions, I will be happy to answer.
Okay, thank you very much, Dr. Wondwossen, for the amazing session you just delivered. We have very few questions. I again encourage the attendees to send your questions on the chat box and on the Q&A box as well. But until then, let me share some of the questions that were sent on the chat box. So can you hear me, Doctor?
Yes, I can hear you. Are you going to share your screen now, or?
Maybe, I don't know, maybe we can send the quiz link first, and then we can give them some time to send more questions.
Oh, I see. Sure. Sounds good. Sounds good. Okay, let me see. I should be able to see those questions too, right? Let me see.
Yeah. Wait.
See here.
Can you please stop sharing your screen, Doctor?
Sorry?
Stop sharing. Oh, okay, thank you.
Okay.
So that I can share the screen for you.
Yes, I see 3 Q&As. Yeah, I can see them from Jonathan, Anonymous, and Liu, right?
Wait. Can you see this?
Yeah.
Share the screen now.
Okay, I see. Okay.
Yeah.
Yes. So what are the criteria to administer TPA after 4.5 hours? And is it applicable in our setup? So there are no criteria right now. It has not been studied. It has not been approved. TPA cannot be given after 4.5 hours. What I showed earlier in one study, which was published last week, June 14, from a Chinese study, that they gave TPA for patients after 4.5 hours. But those patients are patients with large vessel occlusion. They are desperate. There is no mechanical thrombectomy for them. It's not available. So basically, they just randomized them to do nothing with just giving TPA, specifically tenecteplase. So they're saying they showed a very modest, very small benefit over standard of care, but that needs to be replicated in multiple other countries, and that is not a standard of care. So to answer your question shortly, no, there is no criteria to give TPA beyond 4.5 hours. Now, second question is it true that according to a recent study, reteplase and tenecteplase could be administered up to 24 hours after onset? Well, that's a good question. No. So reteplase and tenecteplase can be used within 4.5 hours, within the standard of care, because they are third generation thrombolytic agents. They are slightly better than the second generation thrombolytic agent, which is TPA or alteplase. So they can only be used within the first 4.5 hours. Tenecteplase, however, has been shown to be used beyond the 4.5 hours on one study in China. And the study has so many criticisms already. In 1 week, I have seen so many people picking apart on that study. But it can be in the future. So to answer your question shortly, all thrombolytic agents can only be used within the first 4.5 hours. Now, I see more questions on that list. Should I go, or will you select them for me?
Okay, so let me read out the questions for you, then we can answer them.
Sure.
On the Q&A, there is a question from Liu Tamrat that says, can you please update us on the dose of aspirin and atorvastatin for patients with ischemic stroke?
Sure. So for ischemic stroke, we give 325 milligrams of aspirin and 80 milligrams of atorvastatin because probably the only study that showed a 27% more benefit than patients who were not on atorvastatin. It's called a SPARKLE clinical trial. It's called SPARKLE, SPARCLE. That clinical trial showed that atorvastatin at 80 milligrams had significant benefit for patients with ischemic stroke. So we start them at 80, and then we do a lipid panel and so on. Maybe after a few days or a few months, we can bring them down to 40, 20, 10, and so on. But it's important all patients are on lipid-lowering agents, especially atorvastatin, because it has been studied, but all other agents are also helpful. It's not only to lower lipids, as the name indicates. HMG co-inhibitors also have anti-inflammatory effect on blood vessels, because stroke is sort of a pro-inflammatory condition, and so there's a belief that statins can stabilize that inflammatory state. So they have both lipid lowering effect and anti-inflammatory effect. That's the reason we give statins. Aspirin, 325 milligrams is better because it's sort of like a loading dose, but 600 milligrams, 650 is also fine. And then after a while, they can be reduced to 81 milligrams. But they have to be given 325 or 650 when they first come in.
Okay, thank you, doctor. Another question from an anonymous attendee says, how extensively do you have to work up before diagnosing cryptogenic stroke? And when do you recommend PFO closure? And I think he wants us to talk more about drug addiction and stroke in Ethiopia.
Sure. Extensively as possible, because you want to know the cause of stroke. Because remember, the most important thing you can do for a patient is first to try to reverse the damage. Second is secondary stroke prevention, because once you had a stroke, you are more likely to have another stroke. As you may know, 25% of all strokes annually in the US are recurrent strokes. Imagine, it's such a huge number. 20 to 25% of all strokes are recurrent strokes. So remember, if you can effectively prevent a stroke, you can basically save all those, a quarter of stroke patients in the United States at least, and probably the number is going to be similar in our country as well. So to do that, you have to work them up extensively. Now, what does extensively means? They have to have all the known, workups, echo, CT angio, or MR angio, or DSA, ultrasound, whatever is available to look at all the vessels, not just the neck vessels. You have to also look at the brain vessels, and you have to look at the heart. You have to look at stroke risk factors. You have to telemonitor them, because paroxysmal atrial fibrillation can only be picked up if patients are admitted and put on a telemonitor continuously, which is what we do. Sometimes short admissions, will prevent that, but unfortunately, we don't have long-term monitors, Holter monitors. In fact, we don't even have anything beyond 48 hours in this country, which we hope to change in the future. In the West, we not just 7 days, 14 days, or 21 days Holter. We can put a small chip under the chest. This devices can be put in place for years. if need be. They are remotely downloadable. When someone goes into an abnormal rhythm, like atrial fibrillation, a doctor in Chicago can pick it up while the patient is in Texas. So really, we need to get there. We need to go there. But until then, we have to investigate them with everything we have. And as far as drug addiction and stroke in Ethiopia, well, the problem is, I think there is enough drug addiction to cause strokes. The problem is we don't have the UTOX panel that we do in the West. Urine toxicology screens are not available in Ethiopia. You cannot, I mean, at least to my knowledge, since I moved here, I don't have the ability to screen them for drugs, you know, cocaine, amphetamines, and others. We should be able to screen them. If we have those, you know, patient gives urine, immediately screen them while working them up, you know, for other common stroke risk factors. Unfortunately, if you know one, please, you know, let me know so I can bring it to our center. But I don't doubt that, you know, drugs are having a significant role in our society as well.
Okay, thank you, doctor. I think the other question is, what is the place of aspirin in the management of stroke?
Yeah, aspirin is an antiplatelet agent. You know, patients have been randomized to aspirin versus nothing since, you know, I don't know, 30 years ago or so. And patients who are on aspirin have done very well. So it's one of those antiplatelet agents that decreases platelet aggregation, which means it improves blood flow to the part of the brain that is either occluded by a thrombus or to help with collaterals. As you know, a thrombus propagates. Once it lodges, it may lodge more, it may propagate proximally or distally, it might even block larger arteries downstream or upstream. You can prevent that by putting patients on antiplatelets. So those are the advantages of putting patients on antiplatelets, such as aspirin.
Okay, thank you. The other question from anonymous attendee says, were there additional factors for the low TPA rate other than late arrival? Because on the data, there were more patients that arrived within 4.5 hours.
Yes, that's a great question. You know, obviously, we haven't had a consistent availability of TPA also in our country. We do our best to make sure that we have TPA almost all the time. And but you know, there's a problem. Our TPA that we have now in our hospital has been held for 1.5 months in customs. You know, asking us all kinds of questions. To try to clear medications like that, you know, taking that long is sad, but that's our country's reality, which I hope will change. So one is that. And the other is patients may not be willing to take that 6% risk. Maybe sometimes there are, you know, financial issues that could happen. But then we do a CT scan, we saw a hypodensity, they tell us that they came in within 4.5 hours. We have to take them at face value. But when we do CTs, they have hypodensity that prevents us from giving TPA. And or they have other contraindications. Remember, we reported on those few patients that arrived within 4.5 hours. There are not that many, by the way. There are few. But you know, the contraindications are there, and for reasons that I just described, some patients may not qualify for TPA. And by the way, arriving within 4.5 hours, or generally, even in the US, TPA utilization rate in the US is less than 10%, 15% in most places. So it's really not uncommon not to give as much TPA, but at least there, a lot of patients end up getting the treatment. So those are some of the reasons.
Okay. Another question says, do you have any experience with pediatric stroke patients at Axon?
So pediatric stroke patients, yes, but so far we have treated bleeding strokes, hemorrhagic type strokes. We have a 6-year-old, a 5-year-old that we treated. Both of them, for example, the 5-year-old had a cerebellar hemorrhage. She was actually one of our case of the week also. A young little girl who nearly died from a massive cerebellar bleed from a brain AVM, cerebellar arteriovenous malformation, which she was decompressed quickly, very nicely at another hospital. They saved her life. And then after she stabilized, they sent her over to us, and then we embolized the ABM and cured her, and she went home. She did very well. And the 6-year-old boy had a brain aneurysm, a pseudoaneurysm, which we treated with pipeline embolization also. So those are the youngest we have treated. But both of them, and we have an 11-year-old, 12-year-old, of course, 13-year-old. We have a ton of pediatric strokes, but most of them are hemorrhagic types for reasons I mentioned. Now, ischemic stroke also happens in the pediatric age group, and commonly it's from accidents, trauma to their neck. They fall from a fence, they fall from a chair, they hit their neck, they dissect the carotid artery or the vertebral artery, and they develop stroke. So this is mainly traumatic dissection of arteries, either in the head or in the neck. And those ones we treated a lot in the US. But in our short time here, we haven't had a chance to take care of those yet.
Okay, thank you very much, doctor. Another question reads, so if there is a hypertensive patient who's on antihypertensive medication and he or she is diagnosed with ischemic stroke, during the acute management, what do we do about the antihypertensive medication? Should it be discontinued for some day or should we continue?
Yes, that's a wonderful question. And in fact, that's a life-saving question. And thank you for that question. Because, I have seen a lot of places in Addis Ababa where they actively bring down the blood pressure. And I have seen a lot of patients who went to some centers. They saw that the patient's blood pressure was 180, 190. They gave them, all sorts of antihypertensives, including labetalol, hydralazine. And in front of their eyes, they get worse, and then they panic and they send them to our center. And then, until you do non-contrast head CT, you should not touch the blood pressure. If it's a hemorrhagic stroke, of course, you will bring it down to less than 160, less than 140 systolic, depending on your suspicion. Subarachnoid hemorrhage, aneurysmal rupture, probably less than 140, 150. The standard of care or what is in the guidelines is less than 160. But we tend to be very cautious when we see underlying, vascular malformations. However, if it's an ischemic stroke, do not touch it. I said this before in the same forum. Do not touch blood pressure, systolic blood pressure, unless it's about the body response. It's a dynamic process. It keeps growing. And if you mess with it, it grows faster. They will kill all the tissue that's supplied by that artery. So do not touch the blood pressure unless it's above 220 for ischemic strokes. And so you will hold all antihypertensive agents except beta blockers. For example, if someone has severe coronary artery disease, they have triple or quadruple vessel disease, but they also end up coming with a stroke. What you do is you hold everything else except beta blockers, but even those beta blockers have to be halved, at least. If someone is on 50 milligrams, Coreg, what is it called? Carvedilol, then you will halve it to 25 milligrams. If they are on 25 milligrams, you will halve it to 12.5 milligrams, or just leave them on as low dose as possible, just to protect the heart, and hoping that that low dose doesn't bring down the blood pressure. So your focus is to let the blood pressure go as high as it wants to, but then to protect the heart, you just leave a little bit of a beta blocker if they are on it. If they're not on it, you don't need to put them on anything. But yeah, with that little modification, you really don't want to mess with the blood pressure.
Okay, thank you very much, doctor. Another question reads, what is the role of dual antiplatelet therapy in stroke management?
Yeah, so in acute ischemic stroke, dual therapy has been shown to improve outcomes in the early phases, because recurrent stroke risk is front-loaded, which means if you have a stroke today, your risk of stroke, of having another stroke over the next 3 months is approximately at 15%. But half of that 15% occurs in the early days, in the next 7 days or so, which means your likelihood of getting another stroke is closer to your stroke. So preventing these recurrent stroke risk by doubling up antiplatelet agents has somehow become a standard of care. Now, there is a Chinese study which wants us to give those drugs for 21 days. The US study, it's called POINT clinical trial, POINT. They let patients go on for up to 3 months. The duration varies, and investigating them, thoroughly would help you somehow decide how long you should drive. You should let them on dual antiplatelet therapy. Now, in some studies, in fact, dual therapy has been as good as TPA, which is not a standard of care, but there's data out there that even suggests that. However, what we don't know is how long we should leave these patients on dual antiplatelet therapy. So again, investigating them thoroughly, making sure they don't have intra or extracranial arterial disease, and a lot of other factors go into the equation to decide how long you leave these patients on DAPT. But generally, for ischemic strokes, a short duration of DAPT is helpful.
Okay. Another question from Dr. Kadir reads, how can we treat patients with ischemic stroke if they have a concomitant myocardial infarction?
Yeah, so that's a great question. As you know, that's a very, very rare phenomena. We see it once a year, an actual is a blockage of an artery in the brain, which is ischemic stroke, and a coronary thrombosis. It's an extremely rare phenomena. I see it once a year, even in the US. What a lot of people might see, however, is sort of a neurocardiogenic response, a heart strain from a stroke. You might see ST elevation. You might even see troponin leak from the heart. That is a neurocardiogenic response, a stress response. It is not a true coronary thrombosis. You don't have to worry about it. Just focus on the stroke and fix the patient. Now, if you ask me, those patients who are actually showing EKG changes or some leaks in the troponins, do they do as well as other patients who don't have coronary issues? No. Patients who actually have EKG changes and some form of cardiac involvement or neurocardiogenic response, they tend to do worse than patients who don't have those cardiac findings. However, the vast majority of patients, these changes are just because of the stroke. They are not real coronary events. So with that in mind, you just focus on the patient with a stroke. You just focus on the stroke and treat the stroke.
Okay. Another question from Awaka reads, after 4.5 hours, can we use TPA if there is a DWI flare mismatch on MRI?
Great question again. A study in Australia, Extend IA trial, looked into that. They showed some benefit. But again, it was just very few studies, patchy here and there. In fact, I don't know any other study that did that except for that one study. And that has not become a standard of care. See, the safety has not been quite worked out. We don't know, for lack of studies, enough studies to support that notion that if there is no change on flare, if there is no change on T2, the stroke is likely less than 6 hours. So why not? Why can't we give TPA? I mean, we've been asking this question for over a decade, but no data has been able to corroborate that claim, and we don't use it. It's not a standard of care. It is, for now, we call it as risky, and we leave it alone.
Okay. Another question reads from Shatu, what is the role of aspirin for ischemic stroke that occurs due to infectious vasculitis?
Well, generally, if it's a stroke from a septic embolus from vegetation, the treatment is antibiotics. We give aspirin because, like I said earlier, you have a blocked artery, whether it's from an infectious embolus or a fresh thrombus. There is a blocked artery. Thrombus could propagate. You want to promote collaterals to decrease the size of stroke. So aspirin can be given. However, if there is any hemorrhagic conversion, which might happen with septic emboli, then you can hold the aspirin. But as it is right now, there's no contraindication in using aspirin as long as there is no hemorrhagic change.
Okay. The other question reads, should we load with antiplatelets to acute stroke patients who are eligible for treatments before referring them to the center?
Now, if they can, they're eligible for thrombolytic therapy, you should not load the patients with anything, TPA or clopidogrel, because as you know, once you give TPA, you don't want to give any other antithrombotic agent, antiplatelet or anticoagulant, for the next 24 hours, because you would just increase bleeding risk. So please, if they come early, don't waste time trying to load them. If they can be given TPA within the 4.5 hours window, just send them over for treatment. Tuqran Bessa also has TPA. We have TPA. So, just send them over to wherever you feel like you should send them. But if they can meet the time window, do not waste their time loading them with TPA. But if they're not, a candidate for that, for TPA, then you can give them, antiplatelets.
Okay, so the other question reads, should we stop statins, which were started before the stroke, for other indications in a patient who has a hemorrhagic stroke?
That's a great question. The Harvard group had published previously that, low levels of LDL and total cholesterol in general might lead to hemorrhagic strokes because, as lipids are part of the cell membrane and so on. So, leakiness of arteries and stuff could come from, lower levels of cholesterol and so on. So a lot of people, contemplate this idea that you reflected in your question. Maybe we should stop lipid lowering agents in someone with hemorrhagic stroke and so on. As of now, there's no data. You don't have to stop them. Honestly, that study has not gone into change any practice in the US or in the Western world. Because what if they have a coronary thrombosis the next day and die from that? So no, I would not mess with the statins. You could decrease the dose if you want, do lipid panel, and then based on their lipid panel, you could just decrease the dose if you want. And but other than that, there is no strong reason to mess with their statins.
Thank you very much, doctor. The other question reads, what is the recommended investigation modality for a possible ischemic stroke patient with normal initial CT scan? Do we go for MRI, CT, and angiography, or DWI?
Nothing. The short answer is nothing. Just treat the patient with TPA or mechanical thrombectomy. However, TPA, just dry CT, non-contrast head CT, give them TPA. But if they need to be sent they need to go for mechanical thrombectomy, we have to prove there is an occlusion, so we do CT angiography. So really, do what is fast. Please do not waste patients' time. I cannot tell you in the last 1.5 years how many times my heart, was broken because of so much unnecessary delay. Even if you have to do CT, even if you have to do MRI, do it quickly and then send them quickly. Just 2 days ago, some guy stayed 17 hours in a very famous, very well-respected hospital in Addis Ababa, where some great doctors work. They know that. They know it's ischemic stroke. The patient came gaze deviation. His eyes are parked to the right. When you see gaze deviation, that's large vessel occlusion. When they are aphasic, that's large vessel occlusion. When they are neglecting the left side, that's large vessel occlusion. So stroke is a clinical diagnosis. You don't need, CT scans or anything. You see the patient and it's a stroke immediately. But do CT to make sure if it's hemorrhagic versus ischemic stroke. That's all you need to do. Then you have to make quick decisions. So please, in the future, accountability comes in place. In the future, people will start to sue people. You will end up in court. You might lose your license. You might lose the license of your facility. They might shut you down. Maybe some big shot, I'm not trying to scare people. Yes, this patient who stayed for 17 hours at some facility was a father of a minister. So that guy is mad. I don't know. I'm just telling you, it's just sad that, you have a large vessel occlusion in front of you. You have done CT, you have done MRI. Why don't you send them quickly? And if we have the ability to help them, let's help them. Tomorrow, other centers will open up, and we're laying the ground. It's not just because we're asked here, we want other centers to open up, but the culture has to be developed. We have to be able to send them out. After all, if you did CT and MRI, what else would you do this for this patient? So, I really want to tell you that there's not much that you need to do. Don't waste time doing MRV. Something I see that just puzzles me in Addis Ababa. Everybody gets MR venogram. I mean, MRV, venous occlusions are some of the rarest forms of stroke. Maybe in a pregnant woman, in the postpartum period, do MRV, fine, if the patient doesn't have any other risk factors. But what's the point of wasting time, patient's valuable time, by doing MRI, MRV, and all these things which take sometimes hours to do? So please, please, please screen patients with dry CT, non-contrasted CT, and then intervene. And that's what I want to really get across today.
Okay, so the first question reads, based on the current evidence-based practice guidelines, thrombolytic therapy can be given to acute ischemic stroke patients up to a maximum of 9 hours, 6 hours, 4.5 hours, or 3 hours. So doctor, please explain.
Yes, so 4.5 hours is correct, as we extensively covered it in the talk. The current guidelines put it at 4.5 hours. In fact, since 2008, Gregorian calendar, we have been using that time window. It has not been extended yet, and there is no evidence to give it beyond 4.5 hours.
Okay, thank you very much. The second question reads, based on current evidence-based practice guidelines, mechanical thrombectomy can be performed on patients with emergency LVO, ischemic stroke, up to a maximum of 24 hours, 12 hours, 9 hours, 6 hours.
Yes, 24 hours is correct, and I'm glad majority, in fact, the vast majority of attendees answered it correctly. As we again covered it extensively in the discussion, mechanical thrombectomy can be performed up to 24 hours. We just need to do a non-contrasted CT. The score patients on the aspect score that we discussed, and if their aspect score is more than or equal to 6, they can qualify for thrombectomy. And as we discussed earlier, there are some trials that are trying to recruit patients into mechanical thrombectomy, even if their aspect score is less than 6, but those are still ongoing. As of now, we will stick to more than or equal to 6 aspect.
Okay, thank you very much. The third question reads, what's the most common reason for very few patients in Ethiopia receiving acute reperfusion therapy for acute ischemic stroke? Financial, delayed presentation, fear of complication, or religion?
Yeah, I mean, all of them are important reasons, and that's why they're here listed. But from our experience, by far, the most important or the most common reason is delayed presentation, because they come to us ultimately looking for help. And once again, these are not cheap treatments, and I hope they will be in the future. But millions of Ethiopians can afford treatment. And the number one reason for us, at least after they showed up at our center, is that they are beyond the time window. So I hope that will improve.
Okay. The last question we have reads, subarachnoid hemorrhage from a ruptured brain aneurysm is a severe form of stroke. Rebleeding of an already ruptured brain aneurysm is commonly lethal. To prevent rebleeding, it is best to treat the ruptured aneurysm within 96 hours, 72 hours, 48 hours, or 24 hours.
Yes, once again, vast majority of attendees answered this, even if we have not covered this in the talk, and I really appreciate that. And my hope was to at least say a few things on the topic when I was discussing the case reviews. But again, there are a bunch of smart people here, so I'm very happy to see vast majority answer 24 hours. Since the question says it's best to treat ruptured aneurysms within than it is 24 hours, as early as possible. But yes, we can treat them within 48 hours, 72 hours, 96 hours, even beyond. Even beyond. So I think the rupture risk, the re-rupture risk is the maximum within the first 24 hours, and then it starts to go down after 24 hours, but it doesn't become zero. In fact, subarachnoid hemorrhage re-rupture rate from a brain aneurysm is up to 50% over the next 3 months. So brain aneurysms that already ruptured must be fixed. And that perfect window is 24 hours.
Okay, thank you very much, Dr. Wondwossen, for addressing the questions. I would like to give the floor to my colleague Israfil so that he can close this session.
Thank you everyone who attended, and we would like to thank Dr. Wondwossen for his excellent presentation and his patience throughout the time. He has been with us now for almost 3 hours of his valuable time, and we would really like to appreciate that. And for all of you who attended today, we would like to say thank you for your patience, and we would like to apologize for the inconveniences that we have faced. We will try to address these issues as we move forward. And we will also include maybe some tips on how to do the quizzes next time. So without any further ado, I would like to say thank you and end the session here. Hope all of you would have a good night. Thank you all.
Thank you.